3 to identify the loss of vertical dimension. Class 3 is greatly impaired muscle tone. Lip support, because lip is something which is important for supporting the maxillary arch and the teeth. We need to find out whether there is any lack of lip support, whether there is any rolled in vermilion border, which is an evidence to show that there is an inadequate lip support. Now the normal labiolingual angle is 85 to 105 degrees. The lip thickness according to Arnett and Bergman, if it is thin lip it is 6 to 10 mm, and if it is thick lip it is 12 to 20 mm. Lip mobility class 1, class 2, class 3. Class 1 is normal, class 2 is reduced mobility, and class 3 is an abnormal condition where there is paralysis existing. Lip contact is again divided into 4 classes. Class 1 is competent lips, whereas class 4 is an everted lip. Coming on to examination of the temporomandibular joint, we have inspection, palpation and auscultation. Inspection by asking the patient to do all possible functional movements, that is opening, closing, moving the mandible forwards, backwards, right lateral and left lateral, and then you need to evaluate if there is any restriction in movement, opening of mouth, or if there is any deviation of the mandible during inspection. Palpation, the doctor stands just behind the right of the patient, and places the fingers in the preauricular region to palpate and see if there is any tenderness or clicking from the TMJ. Auscultation is used for determination of the crepitus sounds from the TMJ. Neuromuscular coordination is very, very important to be studied because it can affect the speech, and the neuromuscular coordination is important for recording of jaw relation. In intraoral examination, we examine the saliva, the consistency of saliva, because serous and mixed is preferred over mucus, because mucus saliva increases the hydrostatic pressure and holds a tendency to displace the prosthesis. We examine the mucosa to find out whether it is healthy, or if there is any underlying pathology, it has to be treated before we start with the making of the prosthesis. Coming on to frenal attachments, we have class 2, class 1, class 2, class 3. If there is a high frenal attachment or an attachment of the frenum near the crest of the ridge, you need to be doing a pre-prosthetic procedure and get the frenectomy done before you fabricate the prosthesis. Examination of the tongue, we have under tongue you have the position of the tongue, the size of the tongue. If the size of the tongue is macroglossic, then it can displace the prosthesis as it is seen here in class 3. Class 1 is the normal tongue position, wherein the tip of the tongue is in contact with the lingual surface of the mandibular incisor teeth, and the lateral surfaces of the tongue rest on the occlusal surface of the mandibular teeth, thereby stabilizing the prosthesis. The arch size is important to be determined. When the size is large, the amount of support is more, and there is less chances of displacement or loss of retention in the prosthesis as compared to class 3, where there is arch size is small. Arch form is nothing but the shape. You have U-shaped and you have V-shaped. The worst prognosis is found when there is a V-shaped arch form, which can result in destabilizing the denture. This is the ridge form is characterized by the cross sectional of the arch. You have square, V and flat. In mandibular you can even appreciate inverted. Normal is inverted U. Apart from that, with extreme amount of resorption, you can have flat, tall, inverted, short, inverted, and even an inverted W shape ridge form. Hard palate is again classified based on the shape. Soft palate is classified or based on the amount of posterior palatal seal area. Class 1 has maximum amount of posterior palatal seal area, thereby providing more retention to the prosthesis as compared to class 3, which has least amount of PPS area. Maxillary tuberosities could be either bulbous or pendulous. Okay, bulbous or pendulous has to be corrected because it can alter the maxillary occlusal plane. Lateral throat form classification was given by Neal. Class 1 is a deeper retromoelohyoid sulcus, whereas class 3 is a shallow one, which means the retention of the lower prosthesis will be least in class 3 and highest in class 1. The ridge relation is important to be determined to see if there is a class 1, class 2 or class 3 maxillary and mandibular ridge relation. The intraoral space, the ideal is 16 to 18. Sometimes there can be an excessive intraoral space, or the intraoral space could be drastically reduced. In that case, you need to be doing alveoloplasty, or when there is excessive intraoral space shows that there is more amount of resorption, and you should be thinking about alternative procedures or ridge augmentation procedures. Radiographic examination is done to see if there is an underlying pathology, cyst or residual spicules of bones or root stumps, or an impacted tooth, to study the bone, the osseous tissues. Vikal and Scoop used radiographs for determination of the mandibular lower ridge height. And then coming on to prognosis. Prognosis in denture service is an opinion of the prospects for the success of the prosthesis. It can be rated as most favorable prognosis, moderate or least favorable prognosis. Coming on to the treatment plans, it's important that we educate and motivate the patients, make them understand that they are not going to be having their natural dentition, and they need to provide some time for them to get adapted to the dentures. We ensure that there is lack of infection, lack of pestosis, and the tissues are properly conditioned, and there is proper nutritional counseling which is provided along before we start with the commencement of the prosthesis. Under prosthodontic care, we need to decide whether we are going to go for conventional dentures or an implant supported dentures. To conclude, it's important that we maintain we plan properly for the first important appointment, which is very significant. Before we start with CD making, the dentist must have a sense of real concern for the health of the patient and the welfare of the patient to establish necessary mutual confidence.